Hi, my name is Mhairi Kerr and I'm a statistician at the Quality Use of Medicines and Pharmacy Research Centre at the University of South Australia. I'm going to present a study looking at the comorbidity burden in patients undergoing hip and knee joint replacement using the pharmacy-based RH risk comorbidity index. First, we'd like to acknowledge the AIHW who performed the linkage of the datasets required for this project, and also the Australian National Health and Medical Research Council who funded this project. The Australian Orthopaedic Association National Joint Replacement Registry has collected information on joint replacements in Australia from 1999. In Australia, over 40,000 total hip and over 57,000 total knee replacements are performed annually, with total hip and total knee procedural volume increasing by 139% and 161% since 2003. Comorbidity is known to be one of the drivers for this increase, and it is also known to adversely impact patient outcomes following surgery. The aim of this study was to describe the comorbidity profile and temporal trends in comorbidity burden in patients undergoing primary total hip or total knee replacements for osteoarthritis. We performed a retrospective cohort study using data from the Australian Orthopaedic Association National Joint Replacement Registry, linked with medicines dispensing information from the Australian Government Pharmaceutical Benefit Scheme dataset. The patients included were those undergoing a primary total hip or total knee procedure for osteoarthritis from 2003 to 2017, and we only included patients that were classified as being a concessional patient within the PBS. And this was to ensure we had full capture of a patient's medicine use. The comorbidity measure used was the RH risk, which is a prescription-based comorbidity measure which contains 47 chronic conditions identified through medicine use. The RH risk score, which is a count of the number of conditions a patient has, ranges from 0 to 47 and was calculated in the year prior to joint replacement. The results were stratified by those under 65 and those over 65. And this was done because someone getting a hip or knee replacement under 65 is very different to someone who's getting a joint replacement over 65. 85% of hip and knee procedures performed were in the over 65s. For hips, more females than males undergo this type of joint replacement, whilst more males undergo knee replacements. ACEs score is a wellness score given by an anaesthetist prior to a patient undergoing surgery, and this is commonly thought of as an alternative to a comorbidity score. A score of 1 is given to a patient in good health, whilst a score of 5 is given to a patient who isn't expected to survive the next 24 hours. Unsurprisingly, given the severity of this type of surgery, there are not many patients undergoing a joint replacement with a score of 4 or 5, and instead, most patients undergoing a joint replacement have an ACEs score of 2 or 3. Looking at the median comorbidity score, older hip patients have one more comorbidity than younger patients, with a median score of 5 compared to 4 in the younger cohort, whilst there's a median comorbidity score of 5 in both the under 65 and over 65 knee cohorts. Here we're looking at the comorbidity burden over time. For hip patients, the burden remains stable over time, with a median score of 4 for the under 65s and between 4 and 5 for the over 65s, but from 2007 has been consistently 5. For knee patients under 65, the median score tended to be 4 from 2003 to 2010, but then increased to 5, whilst in over 65s, it has been consistently 5 over the 15 years. So we also had to look at what were the 10 most prevalent comorbidities in the year prior to a total hip or total knee joint replacement. The pain comorbidity as measured by opioid use, and inflammation and pain as measured by NSAID use, and depression were more prevalent in younger patients and were comparable across both hip and knee cohorts. In the older patients, inflammation and pain was also a common comorbidity, and so were the cardiovascular related comorbidities like hypertension and hyperlipidemia. and we saw an increased prevalence of these conditions, in particular in the older knee cohort. So these are the trends over time for the 10 most common comorbidities in each cohort. So just pulling out some of the more interesting features in these plots. So in all the cohorts, the use of opioid medication for the treatment of pain increased over time, whilst the use of medication for inflammation pain decreased. And this corresponds with the market withdrawal of the medication rofecoxib in 2004. In the younger cohorts in particular, the prevalence of depression is increasing, whilst in the older cohorts, the prevalence of hyperlipidemia is increasing, which is probably due to the increase in statin use over the study period. Also in the older cohorts, the use of antiplatelets have dropped from approximately 25% in 2003 to 10% in 2017. In patients undergoing total hip or total knee joint replacement, little change in comorbidity burden was observed over the study time periods. There were, however, some differences in the prevalence of specific comorbidities over time, where increases were seen for depression and opioid dispensing, and reductions were seen in the dispensing of NSAIDs and antiplatelets. It's important to recognise that variations in comorbidity prevalence may in part reflect changes in clinical practice and medicine variability. For example, increased prevalence in opioid dispensing mirrors the global trend in increasing use of opioid medicines for non-cancer patients. Further research should be undertaken to investigate the impact of these comorbidities on longer-term outcomes of joint replacement surgery. Thank you.